like to hand it over to Renee Krupleski, who's the administrative director of the Share Network at the University of Chicago, to help set the stage and welcome our guest speaker. So thanks so much, Renee. I'll hand it over to you, please.
Thank you, Lucas. And you stole the words out of my mouth. We appreciate being able to come as a longtime partner with Chicago Hyde Park Village, and just enjoy being able to come and bring as many resources and support as we can, especially as we have some, over the many years we've been together. So, as Lucas said, my name is Renee Kroplewski. I am the administrative director here at the Share Network. For those that don't know me, I've been with the Share Network for a few years now, and have been loving the growth of the relationship, appreciate, the understanding and the educational components that come with. And for those that aren't familiar with the Share Network, just a quick overview. We are a grant-funded program. We're funded through the Human Resources Services Administration, and we have been an organization since 2015, and our goal and overall mission is to truly not only provide education and resources, but to providers and to those that are providing direct care, but also to the community to empower and support as much as we can. So that could mean providing educational opportunities such as this one, or providing our resource guides, which I just saw Susan Alito on Monday, and I know she's excited because our new resource guides are coming out or just came out on Monday, and we'll be delivering those to everyone as well. So, those are just a few of the things to scratch the surface and talk a little bit about Share Network. But speaking of Share Network, we are comprised of quite a few different individuals. We're a small but mighty team. We consist of those who manage data to clinical nurse educator. I'm a social worker by background, but we also have multiple different providers. One of those being Dr. Elizabeth Zavala, who I'm very excited to introduce, and someone that I truly enjoy working with and has so much to share. Dr. Zavala is an associate professor of medicine at the University of Chicago, and she specializes in geriatric care with a focus on urinary incontinence in older women across various clinical settings. Her research addresses health disparities in incontinence care for older African American and Latina women, and aims to improve nursing home education within medical training programs. She's a dedicated educator. She mentors trainees, directs geriatric clinical rotations, and leads curriculum development in aging and health equity, notably through her Merits Fellowship. She's also active in AMDA's Diversity, Equity, and Inclusion Committee, fluent in Spanish, and board certified in geriatric and family medicine. She's a committed clinician, researcher, and advocate for health equity, actively supporting future healthcare providers through HEDI initiatives. And she is someone that I know is going to do a wonderful job with today's presentation. So Dr. Zavala, it's on over to you.
Wonderful, Renee. Thank you so much for the introduction. Lucas, for the invitation. Ms. Dorothy, I love that introduction. Thank you for sharing your story. And I want to say, I heard you mention this is a condition that, you see more with aging or an older age. It is considered geriatric syndrome. And as a geriatrician, I see this every day. I help manage osteoporosis. So it's very much in line with what I feel comfortable discussing. So happy to answer questions. Let me go ahead and share my presentation. Let's see. Let me know if you can see this. Let's see. Are you able to see my screen, my presentation?
Yeah. Looks perfect.
Wonderful. Okay. So again, my name is Liz Zavala, geriatrician, and I'll be talking to you today about osteoporosis. So stronger bones, stronger you. Our objectives, our goals for today. I really want everyone to leave this talk having a better understanding on osteoporosis, having the tools to learn how to prevent and maybe manage osteoporosis, in ways you can stay strong and independent, because that's ultimately one of the biggest goals, preserving quality of life, preserving function. Okay. So what is osteoporosis? So osteoporosis is a condition in where the bones become weak. They can break easily. These breaks can happen silent, Often there's no symptoms until an individual actually has a fracture, and it can really, really affect mobility, independence, and quality of life. Quite literally, osteoporosis means porous bones. So they become less dense over time, they become more fragile. And like I mentioned, unfortunately, some people don't realize they have osteoporosis until the fracture happens. Now, normal aging versus osteoporosis. Physiologically, we're all going to lose a little bit of bone density as we age. As a matter of fact, our peak bone density happens at around age 30. And then afterwards, as we continue aging, we're slowly losing a little bit of that bone density. It happens more rapidly, that bone density loss, after menopause, because estrogen is actually a very important hormone involved in the protection of bones and its bone health. Now, bones, you can kind of think of it as kind of a living tissue. So there are cells in your body that are actively building up bones, the bone density, the architecture of the bones. At the same time, there's cells in the body that are breaking down bones. And usually the cells that make up the bone are in balance with the cells that break down the bone. Now, for whatever reason, say you're a woman, postmenopausal, you lose estrogen, the cells that eat up the bone start kind of outnumbering those cells that build up the bone. So now your body can't really keep up and you're losing bone density. And again, the loss of that bone density is what causes this increased risk of fractures. Now, osteoporosis versus a healthy bone. I wanted to share this picture here. And I did want to share, I apologize, I can't see the comments or any of you. So if there's a questions, please feel free to come off mute and let me know. But I want to talk about osteoporosis and present this picture on what that could look like. So on the left here, you see an image of a healthy bone. You see the nice small little pores, the tight architecture, the netting essentially, and how that correlates to a nice healthy spine. To the right, we have osteoporosis. We see that it's thinner, it looks more fragile, the pores are bigger. And with osteoporosis, that loss of the density, it's very difficult for the spine, in this example, for example, to even withstand your own body weight. And so we have what's called vertebral fractures that can happen that sometimes, like mentioned before, don't come with any symptoms. We may see it in individuals. We may see that individuals start having a curvature of their spine, but not necessarily associated with pain, although sometimes it can be very painful. Sometimes individuals can wake up with very severe back pain, and it is a result of a vertebral compression fracture. Now, how prevalent is it? So it's fairly prevalent. 1 in 5 women over age 50 have osteoporosis, either at the hip, at the spine, or the wrist. And also, about 1 in 20 men over the age of 50 have osteoporosis. 54 million Americans have osteoporosis, or what's called low bone mass, which we'll talk about in a moment, which places them at risk of increased risk for fracture. Now, who are the individuals at risk? So age, individuals who are older in age, generally 65 and older. Being a female, being a woman puts you at a higher risk, but as mentioned before, men are at risk of osteoporosis too if there are other risk factors, which we'll talk about in a moment. Family history. If you have a family history, say a parent who had a hip fracture, a spine fracture, or even have like children who have osteoporosis or suffered from a fracture. People with low body weight. So we're talking about individuals who have probably weigh around 120 pounds. Low body weight is associated with increased risk of osteoporosis. Smoking, alcohol use, certain medications, certain ethnicities like white, Asian, Hispanic descent, and individuals who may have lower levels of estrogen, for example, postmenopausal women. Lifestyle factors that play a role in this, as mentioned before, individuals who smoke, individuals who have heavy alcohol use, individuals who have low physical activity, believe it or not. Physical activity is very important, and we'll talk about it later, but essentially, your bones, your muscles, and your tendons, they're all connected to your bones. So as you work out, as you walk, you're actually working out your bones too. As a matter of fact, this is why astronauts, when they go into space, there's no gravity, so there's not much work on those bones. That's why they develop osteoporosis, believe it or not. As I mentioned before, people with family history, so parents with hip fractures, and certain medications and medical conditions. So medical conditions that put one at risk of osteoporosis can be things like some type of malabsorptive disease. So if you have issues with your gallbladder or liver, celiac disease, individuals who've had gastric bypass surgeries, for example, they can't really absorb calcium like they should, or vitamin D. Um, Individuals who maybe have had some type of hormonal therapy. For example, men with prostate cancer, sometimes they go on a hormonal therapy to kind of reduce those numbers, and that puts them at risk of osteoporosis, and certain medications. I wanted to share this slide with you because uh, some of you may be on these medications or heard of these medications and kind of want to explain how these medications can overall affect your bone health. So steroids, things like prednisone, they decrease bone formation, increase bone breakdown. Sometimes they're prescribed in the setting of some type of lung disease, an autoimmune disease, or sometimes even like a gout flare. Medications known as proton pump inhibitors, so things like omeprazole that are used for gastritis or GERD. They lower your stomach acid and reduce your calcium absorption. Anti-seizure medications can interfere with vitamin D metabolism. Individuals who maybe have breast cancer or certain cancer that that involves like estrogen or a hormone. So these medications, aromatase inhibitors, lower your estrogen levels and thusly accelerate your bone loss. Androgen deprivation therapy, so men with prostate cancer lower their testosterones, but then that leads to bone loss. Certain antidepressants known as SSRIs, like sertraline and fluoxetine, they can interfere with bone remodeling. Medications for diabetes, like pioglitazone, can increase your risk of fractures, especially in postmenopausal women. And then, believe it or not, loop diuretics, which are often frequently used for various things like heart failure exacerbation, swelling in the legs. And they cause or are at risk of osteoporosis by increasing calcium loss through the urine. Now, I want to mention that we have normal bone density loss and then osteoporosis. Right in the middle, we have something called low bone density or osteopenia, low bone mass. It's not quite osteoporosis. It's not quite related to just physiological aging that occurs at the bone. It's right in the middle. It's a category right in the middle, and it's sometimes considered an early warning sign. Now, individuals with osteopenia, you can still have a break in the bones, but it occurs in much less frequency than someone with osteoporosis. And thusly, individuals with osteopenia, the focus in recommendation is very much diet, lifestyle, behavioral supplement management. Whereas in osteoporosis, aside from that, there's also the recommendation for pharmacological therapy or medications. Now, where are these sites of fracture? So commonly they can occur in the hip, spine, wrist, or humerus. Hip fractures are our most serious. Over 300,000 adults age 65 are hospitalized each year for hip fractures. They often require surgery, and 20 to 30% of older adults die within a year of a hip fracture, and only about 1 in 3 patients can regain their pre-fracture level of function. So I want to like pause and emphasize that. That's one of the reasons we're talking about osteoporosis, not really the condition itself, but what it can put you at risk of, these fractures. Women who have a hip fracture actually have 4 increased risk for other fractures within 2 years of that initial fracture. Spinal fractures can cause height loss, back pain, postural changes. Wrist fractures are common from falls and can affect daily tasks. Now, who should get tested? So, according to the College of Family Physicians, American College of Physicians, United States Preventive Task Force, women over the age of 65 should be screened for osteoporosis. Now, there isn't enough data for these organizations to recommend how screening should be done in men. However, the Bone Health and Osteoporosis Foundation does recommend that men over the age of 70 get screened for osteoporosis. And the screening can occur at a younger age if you're someone that's considered a higher risk. So someone who maybe is on medications that increase your risk of bone density loss, or if you're on medications for a long time that increase your bone density loss. Now, how do we diagnose osteoporosis? So one way it's diagnosed is as part of a screening. So you're someone from my previous slide that qualifies for screening. You undergo a DEXA scan or a bone density scan. I'll show you a picture of this scan in a moment, but the scan is simple, it's painless, and it helps us calculate what's known as a T-score. A T-score helps us determine if you fall in a normal category, so bone loss that may be just physiological changes in the bone due to aging, osteopenia or that low bone density, so right in the middle category, or osteoporosis. So a score of about -1 to -2.5 means osteopenia, and a score of -2.5 or lower means osteoporosis. I have a slide coming up that kind of shows this and help you see it a little bit better as to the numbering and the category of bone loss. So this is what a DEXA scan looks like. When you present or when you go for your scan, you'll change out of your clothes. They'll get you a hospital gown. They'll ask you to lay on kind of like an examining table, and that's actually it. Occasionally, we'll have you reposition your leg so that we can better see your hips, but you really just lay there. It's about 15, 20 minutes, and there's a technician that kind of moves the X-ray sensor over you to try to take images of usually your spine and your hip, and sometimes of your forearm. Now, this is the T-score I was mentioning. So this is the data that we obtain from that bone scan. It helps calculate what's known as a T-score. And essentially what this is doing is comparing your bone density to that of a healthy young adult. And so someone with positive numbers, you can see has normal bone density, what we would expect. But as we start getting lower into this negative area, negative -1, for example, to negative right before 2.5. Now, as you can see here, we're starting to see more of these pores, and we're in that low bone mass density or osteopenia. And then as the score gets like lower, so more negative, -2.5, -3, -4, the more porous, the more advanced the osteoporosis is. And this is helpful to help determine not only staging, but the kind of treatment we recommend as well. Now, another way, so that was one way we can diagnose osteoporosis. Another way is if you are someone who has experienced what's called a fragility fracture. A fragility fracture is a broken bone that happens at the hip, spine, wrist, or shoulder. And it's a fall that happened from a standing height or less. So you were walking to your mailbox and you happened to fall, you tripped on a rock, and you sustain a fracture. That's considered a fragility fracture. It's enough to diagnose you with osteoporosis, even if you've never had a bone scan, or if you had a bone scan and maybe it showed that you only have low bone density, but not osteoporosis. Regardless of what that bone density scan shows, you are classified as osteoporosis because you suffered this fragility fracture. And the bone scan actually just serves to monitor your response to treatment. So you're someone that was diagnosed by a fragility fracture, not that gold standard bone density scan. Now, the third way someone could be diagnosed with osteoporosis is by this calculator. This is a calculator called our FRAX calculator, or fracture risk assessment tool. And essentially, it is a questionnaire that asks information like age, sex, weight, height, history of previous fracture, having a parent with a fractured hip, if you're someone who smokes, if you're someone who uses medications like glucocorticoids, like prednisone, someone with rheumatoid arthritis, someone who drinks alcohol. All of these numbers are calculated to help give us a percentage. And so individuals who, after inputting this their information, who are calculated to have a risk of 20% or more for a major fracture, so they're at risk of 20% or more for a major fracture, or a risk of 3% of a hip fracture, those individuals are considered osteoporosis and they're eligible for that pharmacological treatment. So not just lifestyle, behavioral, exercise, supplements. You're someone who also will qualify and benefit from medications. Now, when there's a concern for osteoporosis, your doctor will likely order some lab work. They would order a complete blood count because they're looking for, all these tests are being ordered to look for a potential reason as to why you might have osteoporosis, and what we call secondary cause. So we're trying to see if there is a secondary cause or another mechanism kind of fueling your bone loss, because if there is, aside from treating the osteoporosis, we want to treat that cause or what's causing the osteoporosis. So the complete blood count looks at your red blood cells. It looks to see your white blood cells. And if they're low or if they're abnormal, it puts us down a pathway of maybe you have a blood disorder or a blood disease that's kind of driving your bone loss. We look at liver function tests because similar, like your liver is also involved in the mechanism of vitamin D and calcium and whatnot. So we're looking to see how healthy your liver is. Your chemistry panel looks at your calcium. So we're looking to see, one, are you someone who has adequate levels of calcium? Are they too high? Are they too low? We're looking at your kidney function because kidneys are also involved in kind of the balance of calcium and phosphorus in your body. We're looking at things like magnesium and phosphorus. We're looking at your vitamin D levels because we know individuals who may have lower vitamin D levels may not be absorbing calcium as well. And so one of our goals would be to get you at a adequate level of vitamin D, which is about 30 nanograms. So we look at thyroid stimulating hormone. We check your thyroid because an overactive thyroid can also lead to bone loss. Your parathyroid hormone is actually kind of like the thermostat of the body of the calcium level. So your parathyroid hormone can be overactive in missensing how your calcium levels in the body are, and then causing more bone breakdown and thusly osteoporosis. And for men, we're measuring things like total testosterone and gonadotropin levels, because as mentioned before, these hormones can be protective of bone density. But if we have lower levels, that puts your body at risk of bone density loss. Want to talk about actually, let me go on this slide first. Before we kind of get to medications and supplements, I want to talk about, or medications, I want to talk about supplements. So once you've been diagnosed, once you've had lab work that come back, that looks for maybe secondary causes or a driver between your bone loss, and maybe nothing is found, it all looks normal. You have osteoporosis. Now what do we do? What are the recommendations? So first, we want to make sure you're getting enough calcium and vitamin D. And the recommended amount for calcium and vitamin D does change based on your age. So in older patient population, 65 and older, generally the recommendation is about 1,200 milligrams of calcium in a day. And generally the recommendation is for vitamin D is anywhere from 400 to maybe 800 international units of vitamin D3. So these are available over the counter. Sometimes if you want to take it as a supplement, as a tablet, you can buy it over the counter. They come in combination. Otherwise, you can get this in your diet. And in just a moment, I'm going to talk about the foods that are high in calcium and vitamin D and how you can incorporate them in your diet to help maintain these calcium and vitamin D levels. So what are we looking at for calcium and vitamin D? So we're looking at dairy products. We're looking at fat-free or low-fat milk. We're looking at fat-free or low-fat yogurt, low-fat cheeses, fortified soy beverages. If you're lactose intolerant or have trouble digesting milk, you can try a low lactose or lactose-free dairy product. And essentially one serving size. So if you're having one glass of milk or one serving size of yogurt, in general, is equal to about 300 milligrams of calcium. So if you have one serving of your low-fat cheese or your yogurt, that's about 300 milligrams that count towards your daily 1,200 milligrams. You can also get calcium from your and vitamin D from your vegetables. So those are like our leafy green foods. So things like soybeans, collard greens, spinach, turnip greens, bok choy, kale, broccoli. Um, if you do happen to buy frozen vegetables just because maybe they last a little bit longer, you should definitely choose veggies without butter or any type of cream sauce. You can also have food with added calcium. So some foods are fortified with calcium or vitamin D. So breakfast cereals are tofu, 100% orange juice. And then they have plant-based alternatives like soy or almond or oat milk that also get fortified with calcium. And then more foods with vitamin D would be things like fish, like salmon, tuna, trout, again, our milk or soy products, and certain breakfast cereals. In a moment, oh, you know what? Let me actually, before I get here, I want to finish up the health and the exercise. So I want to talk about, again, the calcium-rich foods and vitamin D. And I think a question a lot of you may have, and kind of how this topic was brought up to be presented today, is the exercise you can do for your bones. So what type of exercises, activities can help strengthen your bone? So one, weight-bearing activities. So that means you don't really need to add extra weight, just using your body in movement is enough. So things like walking, dancing, running, swimming, Tai Chi, yoga, they can help because, as I mentioned earlier, your tendons, they connect to your bones. So if you're in movement, they are working out those bones for you. Strength training is also incredibly helpful and help with your bone, actually build up your bone density. So the use of maybe light weights, resistant band training is also really, really helpful. Exercises that can help with bone density, so movement, as well as balance, because keep in mind that if an individual has osteoporosis, they are at higher risk of fracture. So if they were to fall, they will fracture. So you want exercises that help with balance. So things like Tai Chi and yoga. And it's recommended, if possible, to aim for about 30 minutes every day of these type of activities. Okay, so that was that was a diet, that was exercise, but I want to talk about the medications. So your doctor may recommend medications to address your osteoporosis because we have a lot of research, a lot of evidence that individuals as quick as 12 months on therapy can already start seeing that increase in bone density, can already start seeing that decreased risk in fracture. So the most common medications that are recommended are a family of medication called bisphosphonates. They come in either an oral. This may be your alendronate, resinidrate, or IV infusion or injections. You either take these medications daily, mostly if you take it as a tablet, sometimes yearly if you go in for an infusion. And the duration of treatment is about 3 to 5 years. And the reason it's about 3 to 5 years is that given the body of evidence that we have, we've noticed that yes, you get improvement in your bone density within the 3 to 5 years of the treatment of this medication. However, we also have research that shows that if you are on this medication for longer, you are at increased risk of a certain type of fracture called atypical fractures. So essentially, the medication's doing so good at that bone density, it does the opposite and puts you at a risk of certain leg fractures, hip fractures that can happen. So because of that known risk, usually if you're on this medication 3 to 5 years, your doctor will have that conversation with you about maybe taking a break or a holiday. Because we know individuals who take a break from the medication and are monitored throughout have reduced risk of this hip fracture, the atypical fractures. Now, they do have side effects like all medications. One common side effect is GERD. And if you're someone who has decided to take the tablet or the oral form of this medication, one of the brands has to be taken without food. And it has to be given so without food. And after you take the medication, you have to be able to sit upward for about 30 minutes. And the reason being that if you were to lay down, it can increase your risk of reflux. And the medication can actually irritate and cause diseases in the esophagus. So that's one of the reasons that we ask you if you're someone who can be sure to sit up right after you take the medication and take it on an empty stomach, which can be hard for people because it can also cause GI upset. Another possible side effect is one called jaw necrosis, which if you're someone who has osteoporosis and you've gotten handouts about medications like bisphosphonate, you'll see it is a mentioned side effect always because it can be very life-altering. It's essentially the bone breakdown of the jaw. It's incredibly rare. It happens in a 1 in 10,000 to 1 in 100,000 patient years. So it's incredibly rare, but it's something that we do look out for. So before we even start you on the medication, often we'll ask you, are you someone in the process of getting dental work done? Are you someone who has frequent dental caries? Or in the future, do you plan to be? Because oftentimes to help reduce your risk, we'll recommend that you get that work done before we recommend the medication. Another medication option is one called denosumab, and this is an injection that you get every 6 months. Now, notice here with this medication, it's a long-term medication. It's considered a lifelong medication because we have no good data at this point that says X amount of years reduces your risk, or if you stop taking it, you're protected for the rest of your lifespan. Unfortunately, it's the opposite. We have data that this medication, if you were to stop it for whatever reason, does increase your risk of fracture quickly. That bone buildup that you had is lost very quickly. So if you're on this medication, that doesn't mean that you can't try the others. It does just mean that there's really no recommendation we can give you when it's safe to stop that medication. And similarly, side effects include that jaw necrosis mentioned earlier. Now, the two medications I just mentioned, they're thought of as anti-resorptive medications. So they help with that breakdown. They help slow that breakdown of the bone. Remember those two cells I said? One is building, one is breaking down. They help slow those cells that are breaking down so your body has a chance to build up bone. Now, these third-tiered medications for severe osteoporosis, these are called anabolic. They build up bone. So they are functioning at the level of the cells that are responsible for building up that bone. Now, they're injections as well. They can happen either daily or monthly, and they have different durations of treatment. So the teriparatide, about 2 years in the lifetime. The bottom one is known as an Anevity, I believe, as a brand name. It's about 12 months. And again, as you see there, their side effects can include things like nausea, bone pain, and even stroke or heart attack. So if you're an individual with maybe cardiovascular disease, it's very unlikely your doctor would recommend that Invenity or the Ramosumab. Mentioned these already. So I mentioned to you, it's really important for us to talk about the lifestyle, behavioral, diet, medication ways to manage your osteoporosis, but it's also important to help identify things that put you at risk of falls. So preventing falls at home is really important. So removing throw rugs, any type of clutter, installing grab bars in the bathroom, having good lighting, especially at nighttime, having lights that automatically turn on so you can see where you're going, wearing non-slip shoes, and keeping items within reach can be really helpful to reduce your risk of fall. So it's really helpful if you're someone with osteoporosis that your doctor goes through maybe a fall risk assessment. So reviewing medications that put you at risk of falls. So if you're someone who may be on a diuretic or have blood pressure medications or maybe have diabetes, it's really important to ensure that your conditions are managed and in a stable are stable at the time, because if you're someone with too low blood pressure, at risk of low blood sugar, taking medication that increase your risk of fall, like anticholinergics. Sometimes people use things like Benadryl for sleep, which is known as an anticholinergic, and it actually causes dizziness as a side effect. So reviewing medication and identifying these medications that you could either reduce or stop completely and replace. Making sure you get your vision and hearing checked, because that's also related to your balance, and it helps collect information as to where your body is in space to help reduce your risk of falls. Staying physically active, and using mobility aids if needed. So sometimes if you're someone who suffered from a fall or have osteoporosis, your doctor may also refer you to physical therapy, because physical therapy can do a complete assessment. They can identify if you are weak in certain muscle groups that are important for your stability and your gait and focus treatment on that. They can also help recommend mobility aids like a cane or a walker if needed to help for safe ambulation. And they actually can also teach you ways to safely fall. It sounds a little bit odd, but if you're going to fall, they teach you on ways to help reduce your risk of fracture or further injury if you were to fall in the future. So I just want to let you all know we're almost close to the end on my end. It's never too late to protect your bones. Medications and lifestyle kind of give the best results. We have a lot of data that the two together can help really reduce your risk of fracture. Recommending that you focus on what you can do and try your hardest to stay social, active, and confident. I also want to share this website, the International Osteoporosis Foundation, that has a lot of educational material from things like what is osteoporosis, how can I increase my diet and increase calcium and vitamin D intake. They also have exercises you could do, like step-by-step exercises, and those educational handouts that help you know kind of exercises to do at home to help reduce your risk of osteoporosis and build up your bone density. And in summary, osteoporosis is common, but it's manageable. It's really important to know your risk and to get tested. It's really important to try to combine therapy and lifestyle changes to kind of get the benefit to your bone health. And try your hardest with these methods I mentioned to prevent falls and stay strong and live fully. And that's it on my end. I'm ready for any questions or experience or thoughts you want to share.
Hi, my name is Audrey James, and I'm currently, this year I found out I have osteoporosis. So the direction that I took is to take the every 6 month shot of Prolia. The problem is I've had so many side effects that I'm going to get off of it.
Yes.
And what is good to get off of that? You know, like maybe I was thinking about a pill that you could take weekly. And is that good?
I was about to say thank you for sharing that. And so I'm hearing you say you're on the 6 month injection Prolia, which is the denosumab. That happens to be one of the medications that we have good evidence. It helps your bone density, but if you stop it, we need to have an alternative again, or that bone density is lost very, very quickly. So I would recommend having a discussion with your doctor to see what your T-score, remember that staging, what that looks like. If you're someone who's not too high of a risk of fracture, like usually this individuals whose T-score is about 3 or worse, then it may be beneficial for you to try a bisphosphonate, a medication like the weekly alendronate. And I guess if you don't mind sharing, was the side effect more having like flu-like symptoms or stomach upset, or what was?
Mine was my whole body swelled up. My
Okay.
face was really big. I didn't mind that because it erased my wrinkles, but it made me gain something like 15 pounds,
Okay.
and I'm really off balance.
Mm-hmm.
And
Okay.
I have a lot of other problems that's going
Oh.
with it. And I hope when I get off of this,
Mm-hmm.
I'll go back to my natural self, because I'm very tired all the time.
Yes.
And sleepy, which is really, I've never been like this in my life.
Okay.
So I'm hoping when I get off of this and get on the others, that the side effects won't be the same. So
Yeah, I was going to say, here's the options, Audrey, that I can think that the discussion with your doctor may look like. So they will likely try to recommend one of these bisphosphonates, and they exist in the Fosamax or alendronate, which is a once weekly. It's taken on an empty stomach, and that's the one where you make sure that you can stay standing upright for 30 minutes. Now, the most common side effect is that stomach upset, that diarrhea or stomach pains. That's a big side effect of that one. So if you happen to be an individual who does experience those side effects, your options are the following. One, it does come in a delayed release. It's resinidrate with an R. It comes as a delayed release. And you can take it with food. That's the added benefit. This is one you can take with food, and that helps minimize the GI or the stomach upset. That's one option. The second option is to go in for a yearly infusion, because that kind of helps get rid of that GI side effect altogether. No infusions.
no, I don't want any more shots, because
You
those
got
are really horrible. They tried IV infusion
Mhm.
for once a year. They couldn't
Mhm.
even find my veins, so I don't want those either.
Yeah, well, then I think you'd be a good candidate for that pill. And then keep in mind, if that doesn't work, you still have that third level that also comes as a pill, but that would definitely be a discussion with the doctor.
Will I have that same problem where I can something with your jaw with those, like
Oh, the osteonecrosis.
yeah.
The bisphosphonate, that weekly pill, that risk still is there. It's actually higher, that osteonecrosis of the jaw, the risk is actually higher for the IV formulation. So the tablet has
Yeah.
even lower risk for the tablet. So that's a good part.
And you said something about some of those are rated where you can take them for so many years and then you can stop. Where the one that I had, it didn't have a stop, you know. You have to take it for the rest of your life.
Exactly, because our studies do show as soon as you stop taking it and you don't have any type of other pharmacological therapy, that bone density, your body put all that hard work making, you start losing it very quickly. So that's why they also have you scheduled for your injections. They have the date, they don't want you to miss it.
Thank you.
Yeah, absolutely.
I appreciate that. Thank you so much.
I have severe osteoporosis, and I've done a 2-year Forteo treatment, and I'm getting ready to have the second year of the infusion, and I'm confused about questions of whether these treatments are improving bone density or whether they're preventing further deterioration.
Yeah.
My impression from my doctor was it was the latter, that these were not going to actually improve my numbers, but they have kept them at the same level.
The hope with the medication for Teo, it's an anabolic. That one's an anabolic medication. So that's actually building up. So we would like to see more bone buildup. That medication is activating more of those cells that help with bone buildup and thusly helping reduce your risk of fractures. The other medications I talked to you about are anti-resorptive. So those are the cells that are in charge of that bone breakdown. The bisphosphonates I mentioned, the prolia denosumab, those are the anti-resorptive. So those are the ones that kind of slow down the progression of bone loss. Mhm.
I have, parenthetically, I've been very fortunate. I have never broken a bone.
That's
That's
that's the goal.
What's that?
Hello.
Hi, Sylvia.
Am I with you? Okay.
Yes.
On the matter of diet, and I
Mhm.
hear this so often on diets,
Mhm.
is why the low-fat milk, cheese, etc. I
Mhm.
mean, I'm somebody who tends not to gain weight and has to make sure I don't lose weight.
Mhm.
And I also find if I eat too much low fat, my skin gets very dry.
Mhm.
So why the recommendation of low fat?
Not for you, Sylvia. If you're someone who's losing weight and you're someone who generally has a hard time keeping on to those calories, the recommendation's opposite for you. Whole milk is great. It's for mostly individuals who maybe don't need the extra calories, maybe have higher cholesterol or some other cardiovascular reason why they shouldn't be on the whole milk or the 2%. But if you're someone who's looking for a way to get added calories and calcium, whole milk is okay for you.
Well, that's good. I mean, the whole milk stuff tastes better.
It really does.
Yeah, thank you.
Of course.
Doctor, I'd just like to thank you for providing for me a good context to think about living with osteoporosis. For me, I am very much against medical interventions for anything, and to a fault. And you really helped me see that it's not an either or thing, either medication or lifestyle, but the two working together. So you've helped me a lot. Thank you.
Awesome. Thank you, Dorothy. Glad to hear.
I have another question about exercise.
Sure.
I don't want to take medication. I haven't been diagnosed, but I'm sure it will eventually come. With exercise, like you mentioned, 30 minutes a day, but you also mentioned a lot of different things. I mean, should we do some of each for 30 minutes a day, or?
That's a wonderful question, Sylvia. I would say any minute, any seconds that you're doing any activity, if it's walking in your kitchen, if it's dancing, if it's cleaning, all those minutes count towards exercise. So at the end of the day, if you spend 5 minutes kind of walking to this room and cleaning that, going up the stairs for another 3, you add the 5 and 3, that's your, your 9 minutes and you're good. All that counts. You don't have to do 30 minutes of uninterrupted exercises. All of it counts, as long as it's 30 minutes in the whole day.
How about the weight training?
Absolutely. So the body weight training is enough. So you don't really need light weights. If you're someone who you feel you're ready for that next level, you can incorporate some like 1 pound, 3 pound weights, but your own body weight is enough to help work out your bones. As you get up from your chair, the tendons that connect to your hip, they're pulling at that bone. So they're working out that bone. As you're taking steps, all those muscles are acting on the bone. They're causing stress. That's working out the bone.
Okay.
I'm going to jump in here and say that Sylvia is one of the members of our chair yoga group with Janae Powell for the village. And Audrey is also, and this is what we're doing all the time. Twice a week from 8 to 9 on Monday mornings and 10 to 11 on Thursday mornings. Ernestine is also part of that. So we're working our bones with chair yoga.
Wonderful. That's wonderful.
Are there other medications that work to build bone?
So are there other medications that work as anabolics? Those are the 2 main ones that we study. So it was the teriparatide, the one Mr. Hoffman, I believe, is on, the teriparatide. That's one of them. The second, Yes, the Forteo. The second one is Inevity, I believe it's called. It's the Ramazumab. Those are the two that are more commonly used that help build up the bone.
Uh-huh. I have friends who are taking Prolia,
Mm-hmm.
and they claim that it builds bone.
That Prolia, kind of like the bisphosphonate, it builds bone because it slows down those cells that eat away bone. So if you
I
have
see.
cells that are actively eating away, you take the medication, it's slowing it down. So those bones that cells that build bone are able to catch up, and they're like, okay, now's my chance to build up that bone. So in a sense, you do have that bone growth, but it's not due to bones that we're activating more of those bone cells. They're just doing their thing, but they only have a chance because the cells that were eating up the bone are slowed down.
Thank you.
Yeah, absolutely.
Would you say something about forms of supplemental calcium?
Yeah, in regard, like in your diet or in vitamin or
Yes, in pills.
yeah, absolutely. So you can get calcium alone in tablets, or you can get them in combination with vitamin D. So it's helpful for you to know what your numbers are. So it's helpful for you to talk to your doctor about where your calcium level is, where your vitamin D level is. And the reason being, if you're someone with really low vitamin D levels, you would benefit from treatment of vitamin D, high dose vitamin D. So weekly supplementations of a high dose to catch you up. If you're someone whose vitamin D is in close to normal range, which again, we're hitting a number of 30, then you can take it either in your diet or with a supplement, because a lot of these combination supplement pills come in about 600 milligrams of calcium to anywhere from 2 to 400 international units of vitamin D. So before you go out and kind of pick that bottle or to know which one to take, it's helpful for you to know where your vitamin D levels and calcium levels are at.
Is the form of the calcium
Versus calcium carbonate.
Mhm.
Calcium citrate versus calcium carbonate.
So sometimes it's like the elemental calcium involved in it. So each one will have different dosings, but it'll tell you how many tablets to take to get your 1 serving of calcium you need. So at the back of that bottle, she'll tell you the kind of conversion or how much.
How much should we be striving to get our calcium and vitamin D through diet rather than through supplements?
Sometimes it's not even needed at all. If you're someone who in the morning has your serving of cottage cheese and then comes lunchtime and you drink your glass of milk, or at dinner time, it's either more cottage cheese or like some yogurt. Each one of those full servings of calcium, that can count as about 300 milligrams of calcium. So 3, 6, 9, 12. So if you get 4 servings, full servings of calcium in your diet in some way, shape, or form in combination, that's enough. That's 1,200 milligrams. That's what's recommended. Similar for vitamin D, if you have like your bowl of cereal, or if you have a full serving of kale or bok choy, that counts for about 200 international units. So you can get that 2, 4, 6, 8. Also similar, four servings of your vitamin D in your diet.
I was told that Cheerios has a pretty high level of calcium in it. It never dawned on me. So I've been eating a lot of Cheerios lately.
Yeah, it's fortified. Yeah, absolutely.
And orange juice, fortified orange juice, has 300 milligrams of calcium in it for 8 ounces.
Yeah.
Easy way to get a little influx at breakfast time.
Absolutely.
I'm sorry, this is Audrey again. I don't really understand how I got it, because I'm a pescatarian, so I don't eat regular meat and stuff like that. And I even transfer, I don't even like lettuce. I use spinach instead. So I've always eaten that way. And I don't understand, how did I get this? And I exercise a lot.
I'm assuming at this point your doctor likely did that secondary workup and came up with nothing. Unfortunately, it's just one of those situations where your body happened to be someone maybe after menopause, where those cells, those overactive breakdown cells, kind of won the balance battle in a sense. It could be family history. There's so many factors. It's hard to really pinpoint or identify sometimes unless, like I mentioned, you find a secondary cause for it. It
Mm.
happens to be one of those geriatric syndromes. So things like osteoporosis we consider a geriatric syndrome because it's multifactorial. There's so many factors. The way or the type of osteoporosis and how it presents to you, Audrey, may be different for some other person, how the treatment may be different because everyone's unique and everyone has different factors that are leading to their osteoporosis. Where was I going with that? I lost my train of thought. So that's why it's a geriatric syndrome, like so many others, like urinary incontinence and dementia. It's just really hard to pinpoint the exact factors that led for you to have osteoporosis.
Could it be because I had a hysterectomy when I was 34 and I got the patch for the estrogen, but my doctor took the estrogen away because of the age. Could it start because of an estrogen low level?
Absolutely, Audrey. That's exactly right. If you're someone who like maybe hit menopause or that estrogen loss earlier, that's more time your body is exposed without that estrogen. So it's very possible if you're someone who also like had like an early onset menopause, and so your bones have been exposed and been unprotected for the estrogen longer. Absolutely.
Thank you.
Well, one thing is absolutely clear. We all need to talk to each other more about our experiences and not, you know, I have a friend, a European friend, who says that Americans are a bit prudish about talking their health and their bodies. And we should stop being that way, and we should share a great deal more and then get some expert guidance from people like you. So again, thank you.
Well said, Dorothy. Well said. Yes, agreed. Wonderful. Thank you all.